Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer to as many questions as possible. Today's webinar, Cushing's during COVID-19, is presented by Dr. Mario Zuccarello, a professor of neurosurgery and recipient of the John M. Chu Jr. Chair in Neurosurgical Oncology at the University of Cincinnati. Dr. Zuccarello is also a member of the University of Cincinnati Gardner Neuroscience Institute and medical director of the Brain Tumor Center. Dr. Zuccarello did his undergraduate work at the Gymnasium in Catania, Italy. He earned his medical degree from the University of Padova, Italy. He then completed fellowships at the University of Iowa and the University of Virginia Medical Center, Charlottesville, and at the University of Cincinnati. His research focuses on neurovascular disease, skull-based tumors, pituitary tumors, and acoustic neuromas surgery, and the development of how new minimally invasive neurosurgical techniques for the treatment of intracerebral hemorrhage. Now please hold while there's a brief delay while we change presenters.
Good afternoon. Can you hear me?
We can hear you.
And can you see my slides now?
Yep, we see the screen.
Perfect.
Thank you.
I want to thank the PNA for the invitation, and of course I welcome all of you listening to this webinar. I hope the webinar will be informative enough and also will trigger questions, and we will try to answer to the best of our ability. Today, I would not be the only one presenting, but also Dr. Jonathan Forbes will be presenting part of this webinar. Dr. Forbes is a distinguished alumnus of Vanderbilt University. He trained at Vanderbilt, and also he had a fellowship in skull-based and minimally invasive surgery, particularly transphemoidal surgery at Cornell. And Dr. Forbes is member of the faculty, University of Cincinnati, and I had the honor and the pleasure to work with Dr. Forbes. That's why I want to have Dr. Forbes also to present today with me. So what we're going to talk today is a Cushing disease, and we're going to go through the 6 points. First will be the explanation of Cushing disease. So the question is, what is Cushing disease? Cushing disease, like many diseases of pituitary gland and other glands, is a hormonal disorders. And the disorder is chained to the level of cortisol. And so the higher is the cortisol in the body, the higher the chances to develop a Cushing disease. So why Cushing disease happens? Typically, you have a tumor in a pituitary gland. And the pituitary gland, as you know, it's the place where all this hormones so this is somehow controlled. And so the pituitary gland produces something which you call ACTH. And this ACTH goes in the bloodstream. Eventually, as a target is the adrenal gland, which is a small gland on top of the kidneys. And this gland starts producing cortisol. So if we have too much ACTH, then the cortisol production will go up, and so the Cushing disease, unfortunately, will be developed. So 2 major hormones to remember, ACTH and cortisol. So few definitions. Everybody knows what pituitary gland is. It's the master gland of the body. As I said, releases ACTH. The adrenal gland, like I said, is a small gland sitting on top of the kidneys. And in response to ACTH, you have a production of cortisol. The cortisol goes to the bloodstream, and the excessive amount of cortisol will, of course, damage the body. creating the Cushing. So Cushing syndrome means if somebody has a elevated cortisol in the body, it can have some changes similar to Cushing disease. The Cushing disease is typically related to pituitary production of CTH and then increased cortisol. So the Cushing disease has to be a pituitary problem. Okay, syndrome means that anyone who has high cortisol can develop a body changes which resemble Cushing disease. And ACTH, like we said before, is the hormones which the pituitary gland produces and stimulate the production of cortisol. Okay, so again, remember pituitary gland, ACTH, adrenal gland, cortisol. If too much ACTH, there will be too much cortisol, which is Cushing disease. So typically the tumor in the pituitary gland is a benign tumor. It's a benign tumor, it's just called pituitary tumor, of course. And again, this benign tumor produces ACTH, and then eventually cortisol will be released by the adrenal gland. However, sometimes there are other conditions which lead to increased cortisol, one of which is not very common, but if somebody has a lung cancer, for whatever reason, some of these lung cancers can produce this ACTH, which is not usual. It's not what you find, but the production of CTH will stimulate the production of cortisol, and so the patient will develop a condition which is similar to a Cushing disease. If somebody takes too much of a glucocorticoid, too much steroids, he or she can develop changes in the body which are similar to those changes which occur when somebody has a pituitary tumor producing ACTH. Or sometimes the pituitary gland doesn't have a real tumor, but as the cells are getting larger, they call hyperplasia, which means that the pituitary gland cells are much larger than normal, and so be like able to produce more hormones and so stimulate more cortisol production. It's not very common, but the number one is definitely a benign tumor of pituitary gland, which causes Cushing syndrome. Just to remember that. So, and this is a schematic. So the pituitary gland produces ACTH. The ACTH eventually goes to the adrenal gland on top of the kidneys, and this put a cortisol. Now, the cortisol should stop the production of ACTH as a feedback. However, if you have a tumor, the tumor does not respond to that, and so we'll put more ACTH and more cortisol, and that's why you have a Cushing disease. Eventually, the pituitary gland is under the control of the brain, but which has some factors which will control this. But in case of pituitary tumor, this doesn't work well, and so this loop is practically what really counts. So again, one more time, you have ACTH tumor, a tumor which produces ACTH. The normal mechanism which control this loop doesn't work. Again, remember what I said before, this control ACTH cortisol doesn't work because the tumor does not respond to the feedback or the production of cortisol. And so you have excessive cortisol, hypercortisolism, which means too much cortisol in the bloodstream, and then the development of Cushing disease with all the typical changes. And the signs and symptoms are very typical. There's acne development, there's moon face, and another thing which is very typical is the purple striae, which you will see in another picture. And sometimes, patient can have increased body and facial hair, some weight gain, and very importantly, the too much steroids in the body can lead to also loss of muscle bulk, and the skin becomes very, very thin. All this stuff are seen in patients with a Cushing disease, but particularly the patient who will complain of this acne, the moon face, the purple striae, and the increase of body and facial hair. And this is in fact what the way they look, okay, and the moon phase. So how to diagnose a Cushing disease? First of all, the most important thing is to ask the patient. The patient will tell us the changes in the hair on his body, and the changes will guide us in the direction of diagnosing a Cushing disease or Cushing syndrome. Then, of course, this has to be supported by some other evidences. So the history and the physical exam will be the number one, number two. I still talk to patients before I look at the MRIs. And I think that's very important because just talking to the patient and examining the patient, many times diagnosis can be easily found. But then we need to go on more testing. So number one is 24 hours urinary cortisol and midnight salivary cortisol. And there's another test which you call low dose dexamethasone suppression test, which means that you try to see if you can control the production of cortisol by giving usually PO and IV a different type of steroids, which is called dexamethasone. The dexamethasone should suppress the production of cortisol. And then after we know that there's too much cortisol in the urines or in the saliva, and then this high dose dexamethasone suppressions will usually suppress it with high doses, and this will give more help, and somehow we support the diagnosis of Cushing disease. And ultimately, you want to see a pituitary tumor to be absolutely sure that a patient has a Cushing disease and not a Cushing symptoms and signs which are triggered by something else. And so the MRI is the gold standard. The MRI with a special MRI they call a very thin cut MRI for pituitary, and it's done in a way a patient get contrast after the first series of images, and it's a dynamic MRI, which also can be useful. Why dynamic MRI? Because try to show the area where the contrast will be higher doses, so we pull the contrast so to see even small pituitary tumors. And again, all this sometimes not even sufficient. And all this, even the MRI, if you have a very small pituitary tumor, you cannot see it. It has to be big enough to be seen. So if you really have high suspicion that the patient, despite the fact that the MRI is not very clear, that there's still a potential small pituitary tumor, there's a test which is called inferior petrosal sinus sampling. It's a pretty big name, IPSS. What does it mean? It means that the pituitary gland is here, and all the hormones are eventually dumped into the system, which is called superior petrosal sinus and inferior petrosal sinus. So the radiologist or the interventional neurosurgeon, like our colleague Dr. Prestigiacomo, will put a catheter into the jugular vein all the way to this area and try to sample blood. Now, this blood comes directly from left and right side of the gland. So if we sample blood on the left side and the level of CTH, cortisol, they are elevated, okay, then we are pretty sure that there's something wrong with the pituitary gland, even if the MRI doesn't show a very large pituitary tumor. So the sampling of blood to confirm a diagnosis sometimes is needed when we think the patient has Cushing disease, we think the pituitary gland is responsible, but we don't have a clear evidence from the MRI. So then you go to this very invasive procedure. It's pretty safe in the hands of the experts, of course, which will give to us the final answer that we need before we do any intervention. So, and now we have a couple of slides, and then we'll have Dr. Forbes to present the rest. So how to treat it? Number one, there's a medical management. Now, the medical management is not necessarily always very successful, but it's there. And in some cases is the way to rescue patients. So there are some medications will control the secretion of adrenal gland, so directly acting on the target, which is the adrenal gland. Remember, the adrenal gland is a small gland on top of the kidneys. Another medication will decrease the ACTH production, which means the pituitary gland production will be decreasing, and so the target, which is the adrenal gland, will not be solicited, and the production of cortisol will go down, and so the patient will have a benefit from that. Or the adrenal steroid inhibitors. So this act directly on the adrenal gland again, inhibiting the production of the cortisol. And all this have a role, of course, and we need to keep in mind that some medical management exists. And the other management before we discuss surgery is the radiation. And we are dealing with a very, very small tumors. So because of the size of these tumors, it's important to use something which is equally precise, which is we call stereotactic radiosurgery. And all these radiosurgeries are made in a way that the beam is so precisely directed to a very small area that will spare everything else around it. So there's a way to treat these tumors with radiation. It, in my opinion, is not the first line of attack. It's a way sometimes to treat patients with Cushing disease who do not respond, unfortunately, to surgical treatment or medical treatment. But for you to know that we have something we can offer. So with this in mind, I would just have Dr. Forbes to discuss the surgical management of this pituitary tumors.
Okay, well, thank you very much, Dr. Zuccarello, and for the introduction, and for the first part of that presentation. And so surgical management of these tumors. In contemporary neurosurgical practice, the most common way to address these tumors is through what's called the endonasal approach. So meaning that the surgery occurs through the nasal corridor. Increasingly, this is done using a specific type of camera called an endoscope. And historically, a microscope has been used as well for this purpose. And so for patients or patients' family members or friends out there watching, both the endoscope and the microscope are means of visualization to provide light and to magnify the area where the surgeon is operating on. So in this case, the pituitary gland. Historically, in cases of large or giant tumors, a different type of surgical procedure known as a frontotemporal craniotomy, which involves a very large incision and a lot of bony work and retraction of the brain to get down to the pituitary gland, has been used, and occasionally that still is necessary for certain certain large or giant tumors. For Cushing's disease, fortunately, that tends to be pretty rare, and so in the vast majority of cases, just going through the nose to take the tumor out is sufficient. Occasionally, and this is also tends to be more of a historical thing, but the adrenal glands can be removed, and so even if there is a pituitary tumor that is churning out ACTH, if those adrenal glands are removed, then stress hormones won't be produced, and the patient won't develop Cushing's disease. Now that can be associated with its own set of complications, but in general, the mainstay is going to be endoscopic endonasal approach for resection. And I have two very short videos here on the next few slides that will talk about that. So this is what's called a sagittal image, and so you can see the nasal corridor that's depicted there. So so you can see how you can travel through the nasal cavity in the red arrow, and the yellow arrow, that trajectory takes you to the sphenoid sinus. And you can see when access is gained beyond the face of the sphenoid, that puts you in the sphenoid sinus. And the yellow arrow is the tip of the arrow has just breached the sphenoid sinus. And you can see that that arrow points directly towards the sella, which is where the pituitary gland is housed. And so I'll just talk very briefly about two case discussions that highlight these surgical technique. And in the first case discussion, we have talked with the patient beforehand who was okay using her images here. And so you can see her, and this is, so she was diagnosed with Cushing's disease. And you can see this is her MRI. So she presented with weight gain and with diabetes and some other stretch marks, and was found to have elevated levels of cortisol. And so that was done both on urinary testing as well as midnight salivary cortisol. And so the next step, like Dr. Zuccarello had mentioned, we knew that she had an excess of stress hormones, which is Cushing's syndrome. About 70% of patients who have Cushing's syndrome that aren't taking medications will have Cushing's disease. And indeed, we got an MRI of the brain, which showed, you can see the arrow points to this enhancing mass in the right aspect of the sella. And this was a tumor producing ACTH. So this tumor was producing a chemical that went to the adrenal glands and was causing the adrenal glands to churn out way too many stress hormones. And so, so you can see the another look at the image there. And so in this image here, you can see we had talked briefly about the sphenoid sinus. And so we've gone through the nasal corridor and we've opened up the face of the sphenoid. And now we're just drilling the bone around the sella flush. And so this is the bone that houses the pituitary gland. And the carotid artery is encased in bone out here. And so we're just drilling this flush, and we're opening the sphenoid sinus. And so here you can see that the bone overlying the sella has been exposed, and now we're just drilling the bone overlying the medial aspect of the carotid and the cavernous sinus here, because in her case we need access to that cavernous sinus. And we drill that bone really thin, and then we just eggshell it out. And so you can see here that we have full exposure of the cavernous sinus here, which you can see is this purple thing to the left. And now we're opening the leathery covering overlying the gland, and in dissecting the gland from the dural covering, you can see already we're seeing a little bit of tumor here. And so we go in with this instrument, which is called a ring curette, and the tumor is very soft in consistency, and that has to do with loss of something called reticulin in the substance of the tumor. And so you can see here that we're getting all of that tumor out, and then we get everything nice and dry, and we use a type of dural sealant called adherus. And this is just the postoperative MRI, which shows the tumor has been taken out. And you can see her a few months later, she's already lost quite a bit of weight, which is what typically happens with Cushing's disease after surgery. And so, so now let me go to the next slide. So this is a second case, and this is another younger female, 26-year-old female who presented with weight gain. And so she had a 24-hour urinary free cortisol and midnight salivary cortisol that was elevated. She had a low-dose dexamethasone suppression test. And on this test, where a small dose of dexamethasone is given, and then a laboratory test is obtained the following day to see if the stress hormone levels drop. And so she did not suppress with a low-dose test, but did suppress with the high-dose test, dexamethasone suppression test. and that is concerning for Cushing's disease. And so with this type of presentation, those are the labs that are typically obtained: the 24-hour urinary free cortisol, midnight salivary cortisol, and the 2 dexamethasone suppression tests. And with going into it with a high suspicion of Cushing's disease, we then obtained a dynamic MRI, which identified a suspected 2-millimeter lesion on the left side. Now, because this focus was so small, and because on MRI it's very difficult to definitively identify lesions that are 2 millimeters or smaller, we also went in, we subsequently proceeded with inferior petrosal sinus sampling, like Dr. Zuccarello had mentioned, and this study confirmed a central origin, and did indeed localize to the left, which is where we were seeing the lesion on dynamic MRI. And so with that introduction, I'll play this video. So this is a dynamic MRI, and so you can see this very small lesion here. So what we would call a hypoenhancing lesion, which is indicated by the red arrow. And so let me go. And so the next, so again, so this is a surgical video here. This is a very short surgical video. And so you can see here that the sella has been exposed, that the dura has been opened, and this is the substance of the pituitary gland. And you can see this shiny substance is the tunica of the gland. And so we have a specialized knife where we're incising the gland here. And so at this stage, you can see the surface of the tumor comes into view here, and so on occasion, there's a discrete capsule that surrounds the tumor, and so you can see here that we work around the capsule, and we use these very fine micro scissors, and that we can deliver this tumor capsule. And so you can see a little bit of tumor there. And so the capsule around the tumor comes out, and we get everything nice and dry, and then use some dural sealant. And so this is a look at how the lab values typically work after a surgery like this. So you can see on the right, you can see the cortisol values. And initially, this patient's cortisol values were elevated. The half-life of ACTH and cortisol is short, and so you can see that cortisol value starts to drop very soon after the surgery in most cases. So you can see at 2:30 after the surgery, it was 24. And we measure that cortisol level every 6 hours. So at 8 p.m. it had dropped to 4.8, and by midnight it was down to 2.0. And so typically, what most institutions will do, most institutions will hold giving somebody stress hormones until that cortisol drops. And you can see this patient at 11 p.m., she started to become a little symptomatic. She had some nausea. And so we started replacing her hydrocortisone at that time. And most patients after this surgery, because patients are used to having a tumor produce this molecule ACTH, and the ACTH telling the adrenals to ramp up the stress hormones. So when the tumor is resected, it takes a little bit of time for those normal cells of the pituitary gland to remember how to produce the stress hormone in most cases. And so as surgeons, we are always in the early postoperative period. We typically follow these labs, which give us some idea, which is not perfect, but give us some idea whether or not remission has likely been achieved. In rare circumstances, if the labs remain elevated, we'll consider a return to the operating room for an additional resection. And so you have to be careful with that strategy. Historically, that was a much more common strategy. Nowadays, with dynamic MRI and some of the other advancements, it tends to be rare that we have to do that. And so, so in general, in terms of the nadir cortisol, we like it to drop below 5, like in the case that we just showed. So the recurrence rate is going to be less than 10% based on some studies. And if it drops below 2, the recurrence rate is going to be even lower than that. So, with that being said, that kind of brings us to a conclusion here. So I'm going to turn things back over to Dr. Zuccarello, and if there are any questions that anyone has, we'll do our best to answer those today. So thank you, Dr. Zuccarello.
John, thank you very much. And as you can see, the Cushing disease and Cushing syndrome are very complex, and but very important is to understand why Cushing disease develops, and it's equally very, very important to be sure that the level of cortisol goes down below the numbers that Dr. Forbes provided you, because otherwise the patient is not cured. And this is something that we can cure. So it's very, very, very important to have a precise surgical procedure if it's indicated. You guys have questions?
Okay, thank you so much. We do have a couple questions.
Yes.
The first one, how can we control Cushing disease patients complicated with COVID-19?
Oh yeah, well thanks, Dr. Zhu. I'll stick in here. So so COVID-19 has provided some challenges, and I think so I believe this question may be referring to a patient with Cushing's disease who has COVID-19, and so you know, in general, like Dr. Zuccarello had mentioned, the stress hormones, in addition to some of the other maladaptive things that happen, the thinning of the skin, the weight gain, they also suppress the immune system. And so, patients with Cushing's disease or some element, or even recovering from surgery for Cushing's disease, have to be careful because they're much more susceptible to this type of infection. And so, I think in terms of some of the precautions that are out there, if you or a family member have Cushing's disease, or if you're recovering from a surgery, you just want to make sure that you go the extra mile with the precautions, because a COVID-19 infection could be a very dangerous thing. And I don't know, Dr. Zuccarello, would you add anything to that?
So, like Dr. Forbes said, the importance of Cushing disease and COVID is the immune system. Okay, patient with a high dose of cortisol, or even patient taking too much steroids for a number of other reasons, like bad arthritis, rheumatoid arthritis sometimes, or other conditions, usually has a suppressed immune response. So number one is patient Cushing. Everybody try to avoid, of course, COVID-19, but patient Cushing disease has to really make any effort to contract the coronavirus. Number two is, in your question maybe also asking, if somebody has Cushing disease and need to have surgery and it's COVID-19, what are you going to do it? Well, it's very difficult because one of the area of major concern in surgery is the nose and the airways, because the COVID-19 coronavirus will be present in that particular area, in what they call the mucosas. So this poses an enormous risk for also not only the surgeons, but the entire operating room and all the personnel in the operating room. There are ways to do surgeries using extremely complex precautions, including special type of ventilation, special type of masks, and almost helmet. You need to be completely covered to do surgery on patient with COVID-19. But it's very, very dangerous for the entire system. So if surgery has to be done because of emergencies, any possible precautions to be taken, but we try not to do surgery on those patients and try to see whether firstly they improve and they become negative. Okay.
Okay, thank you.
You're welcome.
The next question is regarding diagnosis of Cushing's disease. Can CRH test replace a high-dose DEX suppression test?
So that's a great question, and that's a very specific question, and probably that is best answered by our endocrinologist. And I can tell you that here, and I'm very fortunate here, number one, because I have colleagues and mentors like Dr. Zuccarello. Also, our endocrinologist here, Dr. Ruchi Babra, is fantastic. And so we're very fortunate. We have a joint neuroendocrine clinic. So Dr. Zuccarello and myself have access to Dr. Babra. And so when our patients come in, we can have visits at the same time, so our patients can see us and then they can see Dr. Babra, and we can knock both of those visits out at the same time, which is a much more convenient thing. And so CRH stimulation test is not used at our center as a first-line study, and so we typically will start with a 24-hour urinary-free cortisol or midnight salivary cortisol to look for hypercortisolemia. Once we're worried about hypercortisolemia, it's common to then proceed to the dexamethasone suppression tests. And CRH stimulation tests are used sparingly. But I think I'm not an expert and I'm not trained in endocrinology, but I think in rare circumstances, I think it can be a very useful test. And at certain centers, I believe that this test is used more frequently than in our center. So.
Okay, thank you. And another question, what are the chances of the tumor to come back? I have 3 small lesions and I'm worried that I'll go through the surgery, but then they will come back.
Well, I think the answer is not the problem that a lesion can come back. The problem is whether the Cushing disease can come back. Because if the lesion is not active in producing ACTH and eventually stimulate the cortisol, that's not a problem. So the problem is, if I have surgery, can I be cured? And the cure is that you need to have a normalization of cortisol. Okay, so and the cure depends upon the accuracy of the diagnosis. So if the diagnosis is accurate, for instance, like Dr. Forbes said, if in the case he presented, if you do a sampling of the IPSS, or the inferior petrosal sinus, okay, so an invasive procedure, but very important in some cases, and you demonstrate that the problem is on the right side of the gland, you go and do surgery on the right side of the gland and you find the tumor, you remove the tumor. If this leads to a normalization of cortisol, then you have a cure. Now, like Dr. Forbes presented, if it's below 6 or below 2, the chances of ever recurrence are very, very low. Unfortunately, you can say 0, but when you have only 2, 3, 4% chances to have a recurrence, honestly, it's pretty good. So almost close to negligible. So the problem is not that the tumor can come back. The problem is, can the symptoms come back? Okay, and so you need to be monitored consistently by expert, and if unfortunately the level goes back up, means that something is growing back. So that's a little bit different way to look at it. This is not like a brain tumor in a brain tissue, and you monitor the size, and the only symptoms will be when it get too large, create a pressure. Now, this can be very, very small, but disastrous for the patient. Did I answer the question?
Yes, thank you. Okay, another question. What kind of risk does COVID-19 present to someone who is pan-hypopituitarism?
So panhypopituitarism. So somebody who's panhypopit is going to be taking DDAVP to help with fluid balance, and is going to be taking hydrocortisone to help replace stress hormones, and is also going to be taking potentially birth control pills or testosterone, and as well as thyroid hormone. And so I don't know. I think under the management of a endocrinologist, I think potentially the risks, the incremental risks are going to be negligible. And so what I mean by that is, if somebody is appropriately replaced, then I think they're going to be, those risks are going to be about the same as the general population, with the exception that if somebody gets sick, communication with the endocrinologist is going to be important, because the body requires more stress hormones. And so a lot of times the dose that's given is physiologic dose hydrocortisone, which is 15 in the morning and 5 in the afternoon. And so in somebody who's sick with COVID, that requirement goes up. And I know Dr. Barbara is very good about talking with patients about the regimen that's used when somebody develops an illness, about going up on those stress dose hormones. And so that's what I would say to anyone who has some element of hypopituitarism, that if that person gets an illness, especially if they're worried it's COVID, to contact your endocrinologist for instructions on how to handle the stress hormones.
Okay, thank you. And our final question. According to the presentation, early post-op drop in cortisol can predict success of surgery. Does the patient need to receive hydrocortisone?
So typically, so hydrocortisone will interfere with the laboratory assay that's done when we're measuring cortisol levels. And so what we typically do, and it can be done differently in different institutions, is we don't give any steroids before surgery in patients with Cushing's disease. So we don't give dexamethasone, and we don't give hydrocortisone, and we measure the labs immediately after. And so hydrocortisone will falsely elevate that assay, and dexamethasone will falsely suppress that assay. And so when that number drops below a specific value, which is typically less than 5 for us, or if the patient develops symptoms, then we will typically initiate therapy with hydrocortisone.
Okay, thank you, doctors, for such a fascinating and valuable presentation. This will conclude our webinar today.
Thank you so much. I want to thank you, not only BNA again, but all the people who has logged in and listened to us. And we will be happy, Dr. Forbes and I, to answer a question offline. If you want to pass my Dr. Forbes email address, we're going to be more than happy to receive, notification from whoever would like to have more questions to be answered.
Absolutely. Thank you so much. We really appreciate that.
It's our pleasure to help. Thank you. You have a great day.
You too. And thank you, everybody, for joining us today. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website, www.pituitary.org, after it is edited. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us and enjoy the rest of your day.
Thank you.
Thank you.
John, did you see that we had 21